Thank you very much, Laura. Thank you for the kind invitation here. I will have the responsibility to discuss the presentation of Dr. Mercer that was focused on multimorbidity, frailty, and disability, and an integrated conceptual framework. I will start from the take-home messages of Dr. Mercer, and will analyze some of them in order to raise some points that I believe are relevant for the discussion. So, first of all, the first two take-home messages. Multimorbidity, frailty, and disability are three related concepts, but they're not really the same thing. Well, I clearly agree, and this is well known since a long time. 15 years ago, more than 15 years ago, Linda Fried published her conceptual framework for frailty, and she clearly identified that these are three distinct but related concepts. Probably multimorbidity was not the concept of multimorbidity was not very well developed at that time, so the term used there was comorbidity. But looking at this graph, really a couple of questions came to my mind that may be relevant for the discussion. First of all, if we look at the interaction among this phenomena, how common are them? If we really want to study a phenomenon and assess its importance, I feel it's important to have data on how common they are and why it's important to link them. So the first question that came to my mind that I'm trying to analyze is, how often do these conditions coexist? I will mainly focus on multimorbidity and frailty because these are probably the hottest topics nowadays in geriatrics and primary care medicine. So as Dr. Mercer has nicely shown, we have recently published in the context of a European project, the Joint Action Advantage, a joint action involving more than 20 countries, European member states, that is focused on managing frailty. Well, in the context of the Joint Action Advantage, our group has reviewed the interaction between frailty and multimorbidity, looking at the prevalence of the coexisting of these two conditions. So 9 articles were analyzed in a meta-analysis, including about more than 14,000 patients, community-dwelling persons, 65 or older. And as you can see in the overall population, 6% of the overall population has frailty and multimorbidity together. I believe this is a necessary starting point in order to discuss about the integration of the concept of these two conditions together. Overall, when we looked at multimorbidity, persons with multimorbidity, we found that about 16% of them, meaning 1 out of 7, has also frailty. So this again gives us some numbers in order to discuss and to identify the size of the phenomenon. But since the issue of frailty is not only an issue for geriatricians and primary care physicians, but is becoming more and more a point also for other specialists that are taking care of other chronic diseases, non-communicable diseases, I believe it's also important to assess the prevalence of frailty in other chronic conditions. And we have done several meta-analyses on different topics, on different chronic conditions, and here the prevalence of frailty in these chronic conditions. So as you can see, about 14% of persons with hypertension have also frailty, 16% of those with osteoarthritis, 21% of those with stroke, 24% of those with anemia, 90% of those with COPD. For atrial fibrillation, we could not perform a meta-analysis because of the limited number of studies, and still diabetes and coronary heart disease have to come. So we can say that also for specialists, assessing frailty together with their target disease might be important. It's an important issue because it's highly prevalent in the patients they are analyzing, they are assessing. Second question that came to my mind. So how often they do coexist? We have a prevalence data. Why we are assessing this interaction? Why is it important to assess the interaction or the overlap among these conditions, and in particular among comorbidity and frailty? Well, I believe that the answer nicely comes from the NICE guidelines on multimorbidity. The NICE guidelines on multimorbidity underline that in persons with multimorbidity, frailty assessment of frailty is a way of identifying people who may benefit from an approach, from a specific approach. A way of stratifying the population with multimorbidity in order to identify those who may need a specific approach. A specific approach that is defined by the NICE guidelines by different points, including establishing disease and treatment burden, evaluating patient goals, values, priority, review medicines, and agree on individualized management plans. So it's absolutely important if the approach is to assess the interaction of multimorbidity and frailty, because this may lead to a different approach from a public health perspective, but also from a clinical perspective. Because if when we treat people with frailty, we should be aware of the fact that most of the time these persons are excluded from studies validating the beneficial effects of drugs. They have reduced life expectancy, so most of the times they may not benefit from preventive treatments. They have increased susceptibility to iatrogenic events, and they have functional deficits that may prevent them to adhere properly. So it's important, there's a meaning in assessing this interaction, because this may bring us to a different approach to our patients from a clinical point of view. Then other two relevant key points raised by Dr. Mercer. Definitions and measurements of the three key conditions he analyzed are not standardized, and there are few gold standards, if any. This is particularly true, in particular for frailty, and I will make this example in the next slides. And the other issue is that a focus on complexity may help to unify these three relevant aspects, these three relevant conditions. So, again, I would like to focus on frailty because probably it's the most challenging part, the condition for which the definitions are still lacking. As I said, in the context of the joint action advantage, we reviewed also available tools for frailty. There are more than 10, more than 15, 18 tools were identified by our review. Wide-ranging applicability, many tools not robustly validated, prognostic ability rarely determined, and many tools modified from the original version. But I would like to be very provoking and bringing a public health perspective on the issue of frailty and its interaction with multimorbidity. And the point I want to make is, do we really need a standardized definition? Do we really need the gold standard? If we have in mind the NICE guidelines and the meaning of frailty, it's a way of stratifying the risk, or somehow of assessing the complexity of the person with multimorbidity, to stratify the risk and to identify people at the highest need that may need a specific approach. Then probably the definition of frailty we adopt should be adapted to the practice or to the context where the physician is working. This is somehow the point we made in the joint action advantage, saying that from a public health perspective, the identification of frailty will remain a way of identifying an at-risk population. And so an instrument to support decision that may change from practice to practice, from setting to setting, depending on the characteristic of that setting, on the number of patients that can be admitted there and that can be treated, on the amount of money that are allocated to that specific setting and context. And I believe that the recently published article in The Lancet proposing a new tool for us to assess frailty in the hospital setting goes along in this line. It goes exactly in this line. It's a new tool that has been developed in hospital, so may be adopted only in the hospital, and is based on electronic hospital records. So I strongly doubt it may be applied outside the UK and outside the hospital setting. But it might be the ideal instrument for that specific setting for hospitals in the UK to identify frailty. So again, from a public health perspective, it may be assessment of frailty in multimorbidity may be a way of assessing patients in need, and probably the tool used to assess patients in need of a specific intervention may vary from setting to setting and from context to context. But if we look at the clinical perspective, then we probably have some kind of standard definitions. And this is one of the of the few we have for frailty. And it's important because it's a clinical definition that is endorsed by the European Medicines Agency, meaning that the European Medicines Agency allowed trials, intervention studies for frailty, given this definition of frailty that is clearly based on function and muscle. So a given condition with its own etiology and consequences. So I go to my conclusions. I hope we will have a good discussion later on. But the points I raise here are the following. I agree on almost everything that was said by Dr. Mercer. Clearly, frailty, multimorbidity, and disability are three related concepts. We still need to understand better how they do interact and why it's important to assess all of them in the clinical practice and in the public health sector. Definitions are different, but probably some of the definitions, especially for frailty, should be contextualized, either to the clinical or public health sector or public health context we are working on. I do thank you very much for your attention.